RTOG is a large cooperative group that exists across the country, has a number of member sites, and they did a study where they tried to figure out how high a dose of radiation they can deliver if they use that Monday through Friday approach of a low dose each day. And what they found out is that the highest dose they could deliver if it was a very small tumor that exposed a lot less normal lung to radiation could go up to a dose of 84 gray. If, however, it was a larger tumor and there was more lung that was exposed to radiation, the maximum dose they could go up to was 77 gray. This is exactly what you didn't want to see. You wanted to see larger tumors being able to get larger doses of radiation, not the other way around. But unfortunately, larger tumors also expose more normal lung to receiving more dose of radiation. So this is a pivotal paper because it tells us what our top-end numbers could be if we were to use sophisticated radiation techniques and deliver this Monday through Friday over the period of several weeks. So how do we do better? How do we improve on the radiotherapy, or how have we improved on the radiotherapy? Well, there are generally three components when you think about radiation that you have to consider. One is, how do I define the target, and can I see the target better and define the target better? How do I plan the radiation? How do I look at the different angles that the radiation is coming in at? And are there any sophisticated tools that I can do to improve that? And then simply the last component is, how do I deliver the radiation? Is there anything I can do on the delivery side of things to improve the radiation outcomes? I'd like to tell you that we've made significant improvements to radiotherapy. We've improved imaging, primarily because radiologists have gotten better with radiology equipment. CT scanners are better. The incorporation of PET-CT, which is a type of scan that involves metabolic uptake, has allowed us to basically more accurately define what size your lung cancer is and whether it's spread anywhere. It's allowed us to more accurately define where the edge of the tumor is and where the edge of the tumor has stopped, where there are normal cells and where there are microscopic cells. In addition, we are doing more work with treatment planning. One of the big improvements in treatment planning has been 4D treatment planning. 4D treatment planning encompasses patient-specific motion in the treatment plan. What that means is that rather than relying on an average where we say, well, tumors generally move 1 centimeter up and 1 centimeter over, we're saying that in Mr. Jones's tumor, this is the motion that occurs to the front, back, right, left. All of those angles are accounted for so that we can make something very specific to his particular tumor motion. Finally, improved delivery. The tools that we have on the linear accelerator side to deliver the radiation are significantly better. They now have built-in imaging devices that allow us to improve the accuracy and precision of delivery of radiotherapy. These tools that have allowed us to improve our ability to deliver radiation on a Monday through Friday low-dose approach to treat the target have also allowed us to start to shift in our thinking about radiation in general. I'd like to suggest that dose escalation, meaning giving higher doses of radiation using even conventional Monday through Friday approaches, is somewhat limited. But it's possible that we could start to think about delivering a very, very high dose of radiation in just a few sittings that would actually be ablative. So rather than just trying to damage cells and then exploit the fact that the cancer cells can't repair that damage and then die, why not talk about delivering such a high dose of radiation that the radiation in and of itself completely eradicates the cancer that's in the space of that high dose of radiation? That's the thought process behind something called SBRT. Stereotactic radiotherapy delivers ablative doses of radiation. To put it another way, it's a tumoricidal dose. It's a dose that's so big that no cell can live in it. So therefore, if we can circumscribe that dose of radiation, just the tumor itself, we should be able to eradicate the tumor. There are a variety of techniques from the computer planning standpoint that allow us to deliver a very high dose of radiation and, in effect, prevent it from spilling into normal tissue to any sort of great extent. So the technology that has enabled this new paradigm has come from a number of different places. PET-CT, as we alluded to earlier, 4D treatment planning, which allows us to incorporate patient-specific motion, improved ability to immobilize or keep the patient steady on the table so we know exactly the position of the patient and the position of the tumor at any given instant. Tools like gating, which mean that the beam of radiation turns on and turns off only when the tumor is in certain parameters, or tracking, which means that the radiation follows the moving target, IGRT, which is image-guided radiotherapy, which is any of the bunch of tools that allow us to build in the radiation the way we want it to show up. Image-guided radiotherapy enables us to actually see the patient on the table just before we deliver that treatment. And furthermore, the tools for delivering the radiotherapy have gotten significantly faster over time. Is there a rationale beyond simply this idea of delivering these ablative doses for eradicating tumors? And I would suggest that there are a few different ways that we could approach this rationale. One is looking at something called the biologic equivalent dose, and we'll talk a little bit about that. And the second is some emerging data around molecular rationale. And the third I've alluded to, which is that the technology improvements allow us to try to approach this. So BED is a term that's thrown around by radiation biologists all the time. And basically what it suggests is that if you do a calculation, you can compare what a low dose delivered multiple times, what the equivalent would be if you were going to give a very high dose just a few times. So it turns out that if you come in Monday through Friday for 5 treatments each week, and you do that for 4 weeks, so 20 visits of 2 gray each, that's going to be 67% less effective than if you just came in 4 times and got 10 gray each. So even though the total dose is the same, it's not the same when you consider the biologic ramifications of that high dose just a few times. What people are realizing is that from the Petri dish, these high doses of radiation can translate to more than 10 plus weeks of daily radiation. The reason that's so important is because we've learned from studies that we can't actually give 10 plus weeks of radiation because of toxicity to the normal tissues. There's some other things that we've learned as well, and that is when you deliver very large doses of radiation, you overwhelm some repair pathways that the cancer cells are starting to develop. Things like HIF-1 and VEGF seem to result in improved cell survival, but at high doses, you can overcome this particular effect. In addition, large doses of radiotherapy overwhelm the ATM pathway. ATM pathways are important in also recovering from the injury from radiation. So if we want to try to overcome some of these pathways that we're learning about, we have to deliver higher doses than we've given in the past. There's some very interesting work that's actually also occurring that may also offer some insight into why the radiotherapy at these high doses is doing so much better than one would have predicted or modeled just from a computer. And it has to do with the fact that when you deliver very high doses of radiation to a small site of disease, you may actually be creating an immunologic cascade that, in effect, pumps up the person's individual immune system to go and fight any microscopic cells that might be left behind.
Thanks for listening. If you like and learn from our GRACEcast, you can subscribe on iTunes by just searching for the term Cancer Grace, find podcasts in the subject you want, pick a format of audio or video, and then just click subscribe. It's that easy. And for those of you who don't want to miss any of our programs, there's even a feed for all subjects. You can also find us on YouTube at Grace for Cancer Info, and that's the number 4 in one word, Grace for Cancer Info. Finally, if you haven't been there yet, please check out our Grace website at www.cancergrace.org. And don't forget that donate button in the upper right. Our content, which helps tens of thousands of cancer patients around the world every month, is made possible by your support. Thanks again.